So our next speaker, I'm very fortunate to have as my office partner at the Ortho Healing Center in Los Angeles, California, who's been at all of the TOBI events and spoken at all of them with me as well, is Dr. Danielle Aufiero, and she specializes in biologics through fluoroscopy and ultrasound guidance. She's a clinical instructor of medicine at the David Geffen School of Medicine at UCLA, and she's here to talk about regenerative biologic therapies and back pain. Dr. Aufiero.
Okay, good afternoon. Hopefully everyone had their coffee and has some energy left for the last few lectures. I decided to talk about low back pain today and biologics, just a general overview. I always felt as a physiatrist before I started doing biologics somewhat limited when it came to the spine. And after physical therapy and an epidural, next thing I know, I'm sending them off to the surgeon when they asked what was next. So I just wanted to share what I've gained over the last few years. And I'm not going to dive into any one particular therapy, but we'll basically be giving you an overview. So the procedures we'll be touching upon today are PRP, BMC, just a little bit, modified epidurals, as I call them, ozone, although once again, Dr. Schallenberger's here, who will be speaking about prolozone of the spine, so I'll just touch upon it. Neural prolotherapy, which Dr. Lamb brought up at his lecture, traditional prolotherapy as a segue to start talking about regenerative therapies. And to even justify why doctors are doing these types of procedures in the spine, especially the PRP and BMC, we really have to go back and look what's led us to this point. And one of the main driving factors is the fact that surgery is just not a great option for a lot of back problems. And when you see patients who have had surgery and they're walking into your office, you know it's going to be a challenge when they have hardware and fusion. It's one of the most challenging cases to treat. So I try to do everything possible before resorting to that point. I just wanted to I was just bringing up the fact that there's risk-benefit ratios of every procedure that you do, but it seems like with the aggressive spine surgeries with hardware and equipment, it gets more and more where there's more of a risk and less of a benefit. So just touching upon post-Laminectomy syndrome and failed back syndrome, just talking about the different challenges over the years with varying degrees of failure rates documented in the literature. And despite the fact that surgeries are improving and getting more technologically advanced, there's still a significantly high failure rate. I mentioned degenerative disc disease and disc-mediated pain being the most challenging because in those situations, you really need to resort to fusions, like Dr. Oliver had mentioned as well. What I thought was interesting is that 1/3 of all of these post-laminectomy syndromes were basically a result of facet-mediated pain in this one particular study that I came upon. And that would be an easy fix. If all of the post-spine patients, if their only problem was facet-mediated, great. You know, you could work on their facets, whether it be radiofrequency or Prolo or PRP, but what about the other 2/3? So I just mentioned here that there really only are a few indications to get surgery in the spine, just to remind everyone, uncontrolled, unremitting pain. So if someone's rolling into your office in a wheelchair crying, came from the emergency room and you do an epidural and it doesn't even touch their pain, you know, the patient really doesn't have much of a choice. Also, progressive or severe neurological decline. That's another indication if someone's losing function in their leg or they have a severe foot drop, you really need to refer that patient. You don't want them to have any irreversible damage. Also, cauda-equina syndrome and long tract signs due to ataxia from myelopathy higher up. So going back to the roots of regenerative injection therapy, It's basically grounded in prolotherapy, which has been around for decades, and I know a lot of physiatrists here have been doing prolotherapy for a long time. PRP and prolotherapy are both within the realm of regenerative injection therapy, but because prolotherapy has been around so much longer, there's a lot more research in the spine with prolotherapy than there is PRP. So just to remind everyone, prolotherapy is a dextrose-based solution. It's targeted at the fibroosseous junctions. It's typically done without guidance. And it's more of a shotgun approach where you're basically injecting all the facet capsules and the ligaments, and you drag it into the sacrum and the SI joint if that's also involved. There's been demonstration of increased ligament diameter in animal models, which was encouraging. A couple of other landmarks. The Lancet picked up its first prolotherapy article in 1987. There was double-blind studies dating back as early as the early 90s. And the Mayo Clinic, when the Mayo Clinic puts prolotherapy in their newsletter, that'll get a lot of attention. So talking about intra-disc problems, that's one area that prolotherapy has not necessarily focused on. Prolotherapy is typically done in these other regions that I mentioned, and it's probably because it's just a technically more difficult procedure. I was able to find one article where hyperdextrose solution was injected into the discs with outcomes up to 18 months afterwards, and it was very promising. And I found it interesting that in contrast, PRP has really only been focusing on the discs. Disc annular disc tears, degenerative disc disease, like Dr. Oliver was mentioning, she reviewed the research nicely with disc pathology and PRP with BMC. So I just wanted to open up PRP and talk about the fact that it's not just potentially helpful in discs when it comes to the back. It could be helpful in joints and ligaments and these other areas. It's just that there is a complete deficiency of literature and research with PRP in this region. So circling back to justifying why doctors should be considering PRP in the spine, the fact that prolotherapy has actually had some promising results, and with prolotherapy, a lot of the studies, they're not distinguishing what particular diagnosis. It's typically a cluster of different diagnoses, but yet it's the same treatment for each diagnosis. So I thought, that makes sense. If prolotherapy is helping these patients, why not try to strengthen it and make it a little bit more powerful with the PRP? I was talking about this gray zone earlier where they're not that bad. They're weekend warriors. They'd like to get back to beach volleyball or play with their child. It's not enough for me to be justifying to go do a surgery, but just felt limited with what else. What if the facet radiofrequency doesn't work? Now what? And obviously, it's best to get them before surgery. So now that we're talking about PRP, just shifting the procedure technique, it really should be modified because PRP is not Prolo. You're using a lot more volume when it comes to prolotherapy, and you typically need at least 6 to 10 sessions conservatively. Also with prolotherapy, I don't know if a lot of the prolotherapists would agree with me, but it usually takes a few sessions to really start getting more sustained relief. So sometimes the patients are coming in, you're doing 1 Prolo, 2 Prolo, 3 Prolo, and you're waiting for them to come back and tell you, yeah, I'm noticing a difference. And it could take 3 or 4 before they really start noticing a difference. I don't want to wait that long, and patients don't want to wait that long. We want to know that we're on the right track after 1 injection. And even though it might not be a home run after 1, there should at least be enough of a difference that this is the right treatment for the patient. So as a result of those differences, there's no way we can inject 50, 60 cc's of PRP into a back. That's just, the patient would want to shoot you, and it's just, it's overkill. So that being said, you only have a certain amount of PRP. It has to be very specifically placed. So that's how the evolution of doing image guidance with PRP in the spine has emerged. You just have to put it right where it needs to be. So I just was reviewing the data again, and this was a nice review of all of the prolotherapy research that had been published up until 2009. And at the end of the day, it's 50-50. Can't say that it helps, can't say it doesn't help, but what they did comment on is the fact that there is a subgroup of patients that seem to respond really well, but it's scattered. So this led me to really emphasize one point in this lecture when it comes to back pain. It's not that straightforward. So you really want to make sure that you're treating the right pain generators before you start recommending these experimental procedures, that patients are basically trusting you to recommend a certain treatment. You want to use their money wisely. So you want to make sure you have the right problem, so that way you could come up with what the best treatment for that problem is, and then be confident and follow it along a specific logarithm. So I even mentioned here that, it's important to do diagnostic blocks sometimes. It's not unusual before I start recommending PRP into an SI joint or Prolo zone, around a disc. I don't do disc procedures, by the way. And that's also why I thought this lecture was nice. You don't have to be a spine specialist to do some of these procedures that I'm going to be touching upon. But it is not unusual for me to be doing diagnostic blocks before I recommend ozone or PRP or Prolo. So potential pain generators, just to review, I know we all know it, myofascial, the cutaneous nerves, once again, John Liftoff's work with neurogenic inflammation, especially when patients have had multiple surgeries or trauma to the back. And this is very classically presented when patients talk about burning in their back. This is the first condition I want to rule out. Ligamentous instability and biomechanical dysfunction, and this could be a very tricky one to diagnose because you can't really see it. It's the ligaments. The ligaments are just a little bit too relaxed. How do you capture that on an imaging study that's static when the patient's laying still? It's very difficult to capture it dynamically with an ultrasound because these structures are so deep. But sometimes you can capture some gapping of the sacroiliac joint in those patients with severe instability. Facet-mediated, radicular, discogenic, SI joint-mediated, and vertebrogenic, which I actually stole that term from Dr. Bay, who is lecturing after me. So I'm not sure if he's touching upon it or not, but this, I was basically referring to the end plates. When patients have severe degenerative disc disease, the end plates of the vertebral bodies in and of themselves become edematous, and they can be their own pain generator. So just diving a little bit into some of these pain generators, ligamentous dysfunction, when the facet joints are a little hypermobile, the muscles around the joints will start becoming hypertonic in an attempt to really try to stabilize the situation. There was a nice study where they basically were able to capture the instability with an osteopath who first would see which joints were hypermobile and if that corresponded to the patient's pain. Also, some of these patients will do extremely well with median branch blocks. So you think, okay, I got it. They have facet-mediated pain, even though their MRI shows no arthritis there. That's usually the first sign. But all of their findings are so classic facet. Why don't they have arthritis? So you do your median branch blocks or you do an intrafacet injection and they feel great, but it lasts for about 24 hours and then they're back to normal. So no matter how much you try to block the pain that comes from the instability, the bottom line is that you're not changing the instability. So radio frequency does not usually work on these patients. And I've always thought that a lot of the failure rate of RFs when patients respond to a median branch block is coming from more of an instability situation. So this was an interesting article that actually Dr. Raul, I think he's here, sent on the TOBI think tank, which is a shared email. And I thought it was relevant for this talk. And they're talking about this whiplash-associated disorder, patients who are in a car accident and they go on to have ongoing neck pain. And as a prolotherapy, I was trained in prolotherapy. Whenever someone would come in with this particular condition, I would get excited because usually these patients do very well with prolotherapy. And the study pointed out the fact that there was increased blood flow to the tender regions, and the tender regions actually correlated to these NSAIDopathies and subtle changes in the ligament with ultrasound. And then right next to these areas of high blood flow were increased sympathetic nerves and sensory nerves. And so it really makes you think about why these patients get better, because as a prolotherapist, I always just thought I was strengthening the ligaments, but now here's this whole new arena of nerves, and I'm sure Dr. Lamb is not surprised because a lot of pain is neurogenic at its very root. So just getting a little bit more into neurogenic inflammation. I'm not going to go too much into detail just for the purpose of time, but there's these TRPV1 receptors that are part of our sensocrine nerves and our subcutaneous, right beneath the skin. And these can get very traumatized. Someone has something drop on their back or fall on their back or have a severe sprain or strain. These little nerves can become inflamed, and unless they're specifically treated, they can remain inflamed for years. Some people's bodies are more capable of healing them, so they don't need additional treatment. But other times, they'll go on, and what will start happening is the capillaries and the blood flow starts getting impeded, and then it sets the patients up to have degenerative processes in deeper areas. So one of the treatments that I'm going to touch upon for the back is neural prolotherapy, and considering a trial of doing neural prolotherapy before you start doing your invasive procedures, especially for patients who present with that burning, deep, achy pain that does not sound facet-mediated. Also, the beauty of neural prolotherapy is that when you do the procedure, you don't put any anesthetic in it. So you do the procedure, you target the affected nerves, usually it's the superior and inferior cuneal nerves in the back, and within 5-10 minutes, if it wasn't too painful for them to get the procedure, they can notice an immediate effect, and there's no lidocaine in these injections. So then you know right away that's the diagnosis, and then the treatment is more of these injections. So I'm going to just touch upon ozonotherapy. Very few complications in the literature. The ones that are out there in regards to spine usually are secondary to intradiscal injections. And what I've found, and which matches the literature, is that you really don't need to put the ozone in the disc, even if the disc is the problem. Because it's a gas, you don't need to be on top of the structure. So even doing it epidurally or through the ligaments or the joints, even intramuscularly, there's not been a statistically significant difference when research has checked it either epidurally or in the disc. It's nice also as a PRP adjunct. There's some biophysiological changes that the ozone will do to enhance PRP. Clinically, it's hard to say, but it does seem to cut down on post-PRP pain afterwards. And I listed some biologic effects there. There's been a ton of research. I listed 5 nice articles in my reference section at the end that you can go back and look at, but we're talking 2,500 patients, 3,000 patients throughout Europe mostly, double-blind controlled studies, so there's a lot of research out there for ozone. As far as herniated discs and degenerative disc tears, this seems to be what the research is focusing on for the ozone. So I mentioned sweet caudal here. This isn't a common procedure, but it's just one that I mentioned under modified epidurals, and you could always resort back to this. It's just using a 5% sugar solution in your epidural instead of just in the neural prolotherapy, which is what I described. There's been mention of doing bone marrow aspirate for pars defects, and this is something that I think should be further explored given the fact that it works nicely for other bony problems like failed fusions. So I'm going to fly through a couple of these charts and logarithms, but I just want people to have it to look back in so that when a difficult patient comes into their clinic with back pain and you're trying to figure out what's going on, you would have these for your reference. So this is just one with low back pain, listing what you have to think of when someone comes in with pain radiating into the pelvic girdle, and the different traditional treatments for each one that we all know about. This is the rhythm, the logarithm more for radiating low back pain and the traditional treatments that you offer for these patients, which these are the ones that when they fail, then they go off to the surgeon. And these are the different workup strategies that I use in my office diagnostically. And you could see all the same things that, diagnostically what we do, as well as neural prolotherapy can sometimes help for a diagnostic trial. These are adjunctive things that you can do as well. And then this is just to emphasize the importance of recognizing every layer of pain generation so that you could address each layer so that you can get the best outcome with your regenerative therapies. And this is basically a logarithm for myofascial pain, and you can look back at this and see the different treatments that can be helpful. This is for sacroiliac joint mediated pain. My go-to is PRP at this point. Disc mediated pain, my go-to is ozone. Facet mediated pain, go-to is PRP with or without ozone. Vertebrogenic pain, this is more, I threw out, this is sort of a random slide, but there's mention of possible antibiotics that can be helpful. Again, I resort to ozone because it's usually associated with disc pathology. And then alternative treatments for failed back syndrome, it's basically a potpourri of everything that I just mentioned, but being really diligent on finding out what's wrong. So you might have to do a shotgun approach when it comes to failed back syndrome. Timing and spacing of regenerative therapies. Typically it's the same like it is in the extremity with PRP, every 4 to 6 weeks for a series of 3, unless they didn't respond at all to the first one. And then just anecdotally, I just wanted to mention I have not been blown away with PRP epidurally. I'm not sure if any other interventionalist has had that experience. So I usually do not resort to PRP as my first line treatment for someone who comes in with a simple radiculopathy. I'd resort to ozone. And just bracing for those patients who have instability after PRP is extremely important. And these are all the references. So I don't have any profound quote how some of the other speakers did. If anyone has any questions, if there's time.
How PRP can treat instability?
So it's the same style as you would for prolotherapy. So basically, I treat the supra and interspinous ligaments. I do that under ultrasound guidance. And then I go into each facet capsule, the iliolumbar ligament, the sacroiliac joint ligament. So I'm basically trying to tighten up the ligaments, trying to create a little bit more thickness in the diameter of the ligaments. I can't get deep, the ligament flavum or any of those ligaments. But the same philosophy is how prolotherapy usually works really nicely for instability is the same concept as PRP.
The grade of instability has any effect on you choosing your patient? Do you either grade 1 or grade 3 or grade 4? Do you still treat them the same?
Yes, so I usually do a series of 3, 4 to 6 weeks apart. And then if they're still having symptoms, there's no rule. So we could keep going, until they hit a plateau. Yeah.
Yeah, hi. I've been doing prolotherapy for about 20 years, and I do all of the techniques that you've been doing. Just to kind of be accurate on prolotherapy, I've been doing it with fluoroscopic guidance for many years. And if you do it with fluoroscopic guidance, you're going to get almost the same results as PRP. Usually takes me 3, 4 visits, maximum 5 visits to get the same results, not 10 visits. I never treat anyone with 10 visits.
Yeah, I was saying
never
more
need to.
Yeah, that's more the traditional model where doctors do them blind.
Right, and the results that they had with prolotherapy were done blindly, and the results were not as good. Now, I think if they repeat the studies with image guidance or ultrasound guidance, they'll be a lot better. Brian Scheipel might be able to comment on that too. I think he does all this as well. Thank you.
Okay, great.